I'm glad to attend this meeting online. My lecture is learn lesion ablation with microwave. How I do it. Before I do the microwave ablation, I did lots of radio frequency ablation. So I transfer to microwave ablation. As we know, the use micro invasive techniques can will not change in clinical setting, and heat ablation is widely recognized as first or second line techniques to cure hepatocellular carcinoma locally. Now, more than nodules, primary or metastatic lesions can be seen with CT, routine CT checkup, especially screening for early lung cancer. But now, skills ablation technique may reduce adverse events and while improving efficacy. I will briefly introduce the ablation technique in lung condition. First, radio frequency ablation. As we know, radio frequency ablation has its own intrinsic disadvantage because water vapor desiccation and channeling progressively increase tissue impedance. And limitation in lines that high impedance to electric current flow and poor heat transfer because the line filled with air. Microwave ablation in advantages and microwave radiate slow all biological tissues and relatively insensitivity to heat sinks. I like the fast procedure because the microwave ablation can produce hotter and larger ablation zone, but the limits of microwave ablation is the persistent air leaks and bronchopleural fistulas, and check quarterly should be avoided. So this is quite different. As first, the previous lecturer showed us that the ablative zone could be awful, but for radio frequency ablation, the ablation zone is usually wrong. But the microwave can produce higher temperature. And another technique is cryoablation. I think the best of the most impressive advantage is no pain. And when I do cryoablation, even in the bone or in the kidney or in the lung, we don't use general anesthesia. And advantage is the visible ablation zone due to isoball and relatively resist to the cold sink effects of ventilation. But the cells located in the peripheral zone of the isoball may be viable. So the isoball should be larger than the lesion. But the procedure time is very, very long. And cryo-shock may take place soon after procedure. And another one is a ground glass or plastic surgical GGO. And GGO happened about 2 to 4% in a lot of persons screened for early lung cancer, and GGO is very common. I don't know the preference of GGO in Pakistan, but it's very common in China, and especially in young ladies. And usually we have multiple lesions in the lung, so it is challenging for thoracic surgeon. It is important that patients with AIs or microinvasive adenocarcinoma receiving sublobal resection and no lymph node dissection have a 5-year survival, recurrence-free survival of 100. It means that most of the lesions as GGO don't have to do some lobar or do the lymph node resection. So as we know that Fractional Society recommendation for GGO is usually most of the lesion should be weight wait for the lesion if it disappear or enlarge. But if it is malignant tumor, usually it never disappear. So we, as a doctor, we must watch the lesion. But for the patient, usually the patient is very nervous about their own lesion. So what's the best method for this patient? It is reported radio frequency ablation proved effective, safe in patients who are unsuitable for surgical resection and has high overall survival survive of 84% for resectable colorectal lung metastasis less than 3 centimeters and low adverse events with radio frequency ablation. And in our institution, we have 85 patients receive CT-guided lung microwave ablation since 2 years, and totally we did over nearly 300 microwave ablation. And some of my colleagues like radio frequency ablation, but I prefer microwave ablation. And microwave ablation conducted in 15 GGL patients who refuse surgery. Most of the patients go to thoracic surgery. So in our institution, we usually use general anesthesia or intravenous infusion of hydromorphone and 3 to 30 minutes before procedure and unconscious sedation. I prefer using intravenous infusion of hydromorphone, but my colleague likes to use general anesthesia. And before ablation, we usually ask the patient to receive contrast enhanced CT, and with microwave ablation, usually we use relative lower power and short time length with 35 to 40 watts for 3 to 5 minutes for small nodules or GGO. And after the procedure, we usually use relieving pain drugs, cortisone, and antibiotics for 3 days after procedure, and follow up 1 month and then 3 months of info. And sometimes for patients that with metastasis in the lung, we usually use chemotherapy or checkmate immunotherapy applied in lung metastasis after ablation. And this technique will usually puncture or ablation zone. We usually never use this direction, but for radio frequency ablation, it could be used this direction. But for microwave ablation, we usually use this direction. And this usually I did like this direction. And sometimes I use this technique to adjust the direction of the puncture, because we hold the cannula at the end at the middle of this needle, and we can change the direction. So this is different. We can usually have 2 centimeters distance of the end. For example, as a simple as this one, we can I want to puncture this nodule, and this needle at first puncture, and we can see this vessel. So we might avoid this vessel. So I adjust this vessel, adjust the needle, and slow this between the vessels and get to the nodule. And this lesion puncture of deeply located GO, and for this patient, 31-year-old male patient, and he is a patient, and he went to the local hospital as a doctor asked him to receive local resection of the lung, so he refused, and I came to meet for help, and so I did microwave ablation. So this because the lesion deeply located near the hilum. So I will illustrate some cases. This is just the case one, and we did ablation of the lesions. The lesions close to the bronchus and the vessel, and but after the procedure, before discharge, the patient developed severe pneumothorax, and 1 month later, we did follow-up, and we can know that this lesion disappeared and became scars and shrinked. This 6-year-old female patient with multiple GGOs and enlarged after 6 years of follow-up, because we can do this lesion, and lesion, and also there are lots of other lesions. So she, at first, the doctors asked him to accept the safe surgical resection, but later she knew that there was a technology of ablation, so she came for help, and we did ablation. We did microwave ablation, and this is one needle, one antenna, and we pierce this one to another one. So with one needle, we did ablation of this lesion, and 1 month later, we can see that lesion shrinked, and we did another cycle of the ablation of this lesion. The needle, we can see the needle is close to the lesion nidus, and after 3 minutes of ablation, we can see that the lesion shrink, and this CT scan soon after ablation, and we can see that this is the cannula of the lesion. This 74-year-old male patient confirmed with squamous cell carcinoma and hemoptysis, who received microwave and seed implantation. We can see the lesion, and this lesion close the hilum and this bronchus. So I did ablation of outer part of the lesion and implanted some iodine seed here near the bronchus to avoid a cavity. The 46-year-old female, and she had multiple lesions, GGOs in the right lung. Here, this lesion close to the pleura, and this lesion close deeply located near the hilum, and this is another one. This one's a little bigger. So we did ablation with microwave, and this one first, and that's this first, and this one. So this 1 month after ablation. This squamous cell carcinoma, male, 81-year-old male patient. He had long history of smoking, and because he's very old, and his relative and himself didn't like to do surgery, so we did microwave ablation of the lesion, and this is the position of the microwave antenna. So the patient, 47-year-old female, and she had a history of breast carcinoma and received operation and also chemotherapy, but there were 2 lesions here. Incidentally found 2 nodules in the lung, and the thoracic surgeon recommended him to receive resection, but she came for help. So at first, before operation, I did biopsy of the lesion, and then did ablation of the lesion. So after ablation, we can see that this lesion became shrinked. This is the radiograph shows this lesion, and 1 week after ablation, she developed right lung right lung pneumonia infection, and 6 months later we did follow up, and with MRI we can see no enhancement. This is another lesion metastasis from the colon cancer, resistant to chemotherapy and radiotherapy in a 51-year-old female, because this lesion became larger and larger even after chemotherapy, and she received 1 cycle of SBRT radiotherapy, and the lesion became larger. So I used 2 antennas to ablate the lesion. This is a CT scan after ablation, but she developed cough, severe cough, and mild fever. And 1 month later, on the CT scan we can find 1 cavity and severe cough and still mild fever. So we gave her medicine to relieve cough, and the lesion became smaller. And we also did a follow-up. We can see the lesion communicate with the cavity, communicate with right bronchus. So this is a lung metastasis of rectal carcinoma in the 80-year-old male. He had lots of nearly 10 nodules in the lungs, and he didn't like chemotherapy because he is also a surgeon, and he rejected the idea of chemotherapy. And we can see the lesion closed oblique fissure, and the lesion is right lower lung. So, and we did MDT, and some doctors suggest seed implantation, but in my opinion, that because the lesion close to the oblique fissure, if we do seed implantation, it may lead to bleeding to the pleura and cause tumor spread. So I recommend ablation, microwave ablation, and this is the procedure. So after ablation, we can see the lesion shrink, and this is another cycle of ablation of the lower lesion. So 3 months later, we can see the lesion shrink. As the lesion shrink, and also I did ablation and seed implantation of the left lung. But after the procedure, he developed a fever and also mild pneumothorax. This lesion is adenoid cystic carcinoma, metastasis of adenoid cystic carcinoma from left nasal cavity, and female, 77-year-old male, female, and we can see lesion. So I did ablation with puncture from this one, and this is a dual procedure, and after procedure we can see that lesion was all ablated. This is lung metastasis of rectal carcinoma in a 54-year-old male, and lesion large after traditional therapies available. He received SBRT and also received systemic chemotherapy and also some other immunotherapy and other target therapy. But the lesions becomes larger and larger, and he came to help. And we can see that the lesions is more. This is a large one, and this is a small one near the pulmonary artery. So I use 2 antennas, one and small antenna, 2 antenna, and puncture from this one and another one to this one, and this is the power in this antenna is bigger, and the power here is smaller. So I did microablation for this large part and small part, and six months later, follow-up showed that all of the whole lesion was ablated, and PET-CT scan showed no activity in the lesion. And sometimes I also do the cryoablation. This lesion here. So I do the cryoablation. But during cryoablation, we can see some bleeding, severe, moderate bleeding, but the pain didn't have any pain. The patient didn't feel any pain, so we don't do any general anesthesia, just the local station. So it's a different. It's a difference from the microwave ablation. So my conclusion is that in conclusion, microwave ablation is effective and safe in treating solitary or multiple lung lesions in patients who are unsuitable for or receive surgery. But we must be familiar with puncture skills, and moderate ablation parameters may decrease severe adverse events. So usually the power of ablation should not be as high as that in radiofrequency ablation. And post-procedure prophylactic measures may relieve patient discomfort. Efficacy of combination of microwave ablation of lung disease with immunotherapy remains uncertain. In my institution, if the lesion is metastatic, usually after the ablation of all the lesion seen in the lung, usually I will give the patient immunotherapy. So that's all my colleagues and our party in a interventional department of our hospital. So thank you for your attention.
Thank you. That was another fantastic talk that we really enjoyed. Very good. It was excellent because overview of lung ablation, and thank you so much for sharing your cases. Dan, are there any questions on the messaging side?
Okay.
We can't hear you for some reason. I think you might still be muted.
Excuse me.
Yeah. What is the antenna gauge that you usually do lung ablation, lung microwave ablation, and do you always do the track ablation?
Oh, in solid lesion ablation, usually the diameter of the gauge is 16 gauge. 16. And sometimes we use coaxial. Coaxial technique. The diameter of the coaxial needle is about 14.
Okay, thank you. That's for now. There's that one question here.
Okay, sure. I had a question. You said that you do most of your lung ablations without general anesthetic, but some of the lesions were quite small, central GGOs, ground glass opacities. Do you ever use high-frequency jet ventilation with anesthesia to help you with those cases? Because obviously, when the lungs are moving, it's a moving target.
In my institution, my colleague like to use the general anesthesia, but before the hydromorphine, I use the hydromorphine to relieve the pain. I think it is effective.
And do you give any breathing restrictions during the procedure to help with the time of procedure that's used?
As the general anesthesia, sure.
Okay. And then another thing is that we saw, I think Zayed was using controlled pneumothorax a lot for sort of preventing the chest wall or pleural injury. Do you use the same technique with microwave or a different experience?
You mean radio frequency?
Yeah, no. I'm just asking that. Do you ever make a pneumothorax to prevent chest wall or pleural injury?
I rarely use that. I rarely use artificial pneumothorax. Because for example, if the lesion is close to a pleural, I will usually hold some leverage the needle, and the tip of the needle will leave the thorax wall. So that usually the patient will don't have to have.
Precisely what you mean. Yeah. So obviously with the microwave needle, it's not the tip. It's sort of more central to the tip, which is where the ablation zone starts. So in contrary to the RFA needle, which is slightly different. Yeah, I understand that.
And the power is very low. Usually the power, the ablation power is relatively very low. Usually I use.
Yes, you said that low power and low time. Yeah. Is there anyone in the faculty who wants to ask a question as well? Just opening it up to anyone in the faculty who's present here who might want to ask a question specifically regarding microwave lung ablation.
Here's one question in the chat box. So what is the worst complication that you had with microwave lung ablation, and how did you deal with it?
Complication? Yeah. One complication is bleeding, and usually it's bleeding, and I think the bleeding is mild. And sometimes during puncture, there will be bleeding. So if there's bleeding, active bleeding, I will use just the ablation to stop bleeding. And another way is pneumothorax, sometimes severe pneumothorax. And if the patient have an emphysema, severe emphysema, I will use the coaxial technique, coaxial needle. And after the ablation, I will use some sponge gelatin plug to plug the cannula. So plug the cannula. That's what I did.
There was one case you showed with a broncho. I think it was a broncho pleural fistula kind of thing. I'm not sure. How was that dealt with afterwards?
Bronchus cavity, bronchus damage.
Air leaked into the cavity, ablation cavity. You showed one case.
In my opinion, the cavity, the reason or why the cavity developed. I think one is the necrosis of lesion, another one is the severe cough. Because severe cough, they expand the cavity. So after relieve the cough with some medicine, and the cavity may become smaller.
Okay, no, thank you so much. So there were a few questions from earlier on from the previous talks that got missed that someone has just texted to me. So I thought that we would give everyone a fair shot. So these are not questions to you, they're questions from the previous speakers as well. Okay, so one of them is someone has asked, how do you microwave ablate a cystic thyroid nodule? So I think this is Dr. Shu had presented on the thyroid ablation. Probably it's best for if Professor Shu is still there, it's probably best for him to answer. If he's not, then I can have a little chat about that as well.
Seems like Professor Shu is not with us at the moment.
Right. So I mean, my understanding, I mean, if correct me if I'm wrong, is that if it's a cystic thyroid nodule, then usually if it's purely cystic, you can treat it by other methods. You don't need thermal ablation. You can inject ethanol and things like that. But sometimes there are thyroid nodules that are both solid and cystic, and there's a role for microablation there. But I think Professor Shu is the expert. I'm just sort of answering on his behalf. There's another question here. Let me see. I think someone's asked about the about hydrodissection or isolation fluid. I'm presuming that's what they mean by isolation fluid, is hydrodissection. So we've talked about a very wide variety of ablation techniques today. We've talked about RFA, we've talked about microwave, we've touched upon other techniques as well, like cryotherapy. It's interesting because I think the flip side is how you dissect and how you protect normal structures, and it depends on what kind of therapy that you're using. So in the lungs, for instance, Dr. Zaid showed us some cases where he created nitrogen pneumothorax, kind of a which is one way of protecting things. And then hydrodissection in RFA, we normally use dextrose. We can't really use saline, but microwave you can use saline as well. And also maybe it'd be worth having a little chat about the heat sink effect, because the heat sink effect affects RFA, but it isn't so much of a problem with microwave. And I think Dr. Zheng also mentioned the cold sink effect, which is quite interesting with ventilation. I don't know, I suppose, does anyone want to say anything in particular about hydrodissection and what they use and how they use it? I don't know if anyone wants to talk about that.
You mean hydrodissection?
Hydrodissection. Yeah.
I use hydrodissection in the liver. In the liver ablation, microwave ablation of the liver lesion, especially lesions close to the diaphragm and close to the stomach or colon. And I usually use some contrast. Diluted contrast. I usually about 5 to 10%. 5 to 10% diluted contrast the saline water, and use relatively lower power ablation. And during ablation, I usually infuse slowly infuse water. And I think that microwave can radiate slow the water, but if we infuse the water can flow, and so that will relieve the damage to the surrounding structure. So that's what I do.
Sure.